And then I think we can start with the data, Zainab, if you're okay with that. And then as others join, I'll let them in.
Sounds good.
Look. There we go. Yeah, so we'll run through the data today first, and then we have Dr. Lazaron to present for us on maternal mental health. She's here for questions as well. And then just a few action items at the end of what's coming up next. And I'll let people in as they come in.
So first of all, I want to thank everybody that submitted their data. We really appreciate that. As you can see in these action period calls, we'll be presenting almost like I don't want to use the word aggregate, but a combination of everybody that's done each of these screening tools. I know some people still haven't submitted their baseline, so I please ask that you make sure that you do that. If you're struggling in any way or if you need any help or any extension, please let us know. But as I said, having this data is important just so that we know where to focus our efforts and we know how to advocate for the patient. So one of the screening tools is the maternal depression screening tool. And as you can see here, at the bottom of the chart, we have baseline months and we have the QI months. In baseline, we had a pretty low screening rate. We are seeing that trend upward. It's still at about a 25%. We are hoping to get that number a lot higher. So again, each practice is going to get their own data that's specific only to the patients that they're seeing. But overall, this is the trend that we're seeing. Again, we're seeing an upward trend, but we still hope to get that a little bit higher as we move throughout the QI months. Next slide, please.
And I'll just say real quick, for some of the baseline data, if practices were not able to track this certain or each certain field, they just entered 0. So that could also be some of the reason that some of the baseline data is low.
Correct. And then these are the results of what we're seeing for the maternal depression. Again, these lower numbers that we're seeing in baseline could be attributed to the fact that we are seeing very low numbers of screenings in the first place. So we could potentially have a higher number of like moms with depression, but we're not seeing that just because the screening tool is not being given to everybody, or you were screening in baseline, or any of these reasons, any of these limitations could potentially be an explanation of why we're seeing pretty low numbers. Next slide, please. The newborn screening in baseline, I feel like a lot of the practices were already had the different screenings for newborns. So we had the cardiac screening, the audiology screening, and the blood spot screening. And each of these is presented by a different colored line on the same chart. We did see a little bit of a decrease in October. We're hoping to bring that number again a little bit higher. However, this is again just a overall level of data of how all the practices are performing, the practices that are specifically doing the newborn screening. Next slide, please. The results of the newborn screening, any positive results again are shown here. And again, this is just to show how all the practices are doing. The whether or not the patient screens positive has no effect on how the practice is performing. Again, this is just for you to know what your patient population looks like. Next slide, please. Food insecurity. This was pretty low in baseline, and we're still treading below 20%. Hopefully, we can get that number higher. We understand that sometimes it can be difficult. However, again, this is just overall how practices are doing. Hopefully, we can get that number higher as we continue through the QI months. Next slide, please.
Can I just interject real quick? Sorry. Is everybody else seeing the slides? I got a message from Dr. D'Souza that's not seeing the slides.
I can see them.
I can see them also.
They're good on my end.
Maybe I'm gonna go with the generic answer of maybe signing out and signing back in, but
Okay, it's okay. It's all right. Thank you.
Okay. Yep.
I'm pretty sure you can access them if you rewatch, or maybe Mark can send out the
yeah, I'll send the slides and the video after today.
yeah, exactly. So I'm sorry you can't see them. Hopefully my verbal explanation gives you a little bit of a clue of what we're seeing.
Oh, yes, it's great. Thank you.
Yeah, you're welcome. And so for the food insecurity, again, these are the results of who screened positive, who, families that said that they had some sort of food insecurity in their household. We had, the number is a little bit less in October than it is in September. But again, this has no indication of the performance of the practice. This is just for you to know what your patient population looks like and what their areas of opportunity could potentially help these patients. Next slide, please. Finally, we have the oral health screening. We do have oral health screening, and we have the receiving fluoride varnish. Not everybody that was assessed, not everyone that had their oral health assessed received the fluoride varnish, and some patients did receive the fluoride varnish but weren't assessed for oral health. So these two are not, like, they don't have to be assessed to receive the fluoride varnish, which I'm sure you already know because you're the ones that are submitting the data. But I did see in some months I did see higher numbers of patients that received the fluoride varnish than that were assessed for oral health. So that's something to consider when looking at these percentages. We did see a little bit of a dip in September and October in our QI months. Again, we understand that implementing a new screening tool can be a little bit challenging or difficult. So, we have seen similar trends in other programs where there's a little bit of a dip in the beginning of the program. But we do see that number, increase towards the end. So please don't be discouraged by seeing, these decreases that we're seeing in September and October. Again, this could potentially be just some limitations that we're seeing because we're implementing a new screening tool. So please keep that in mind when you're looking at your own data as well. In terms of data, this is all I had. If anyone has questions, you can either put them in the chat or ask them individually in email or however you want. Again, we do have individual practice data, which I think Mark will be sending out. And again, if you have any questions about that as well, then please email us. If anything looks wrong, please let us know. It might be that the data was entered incorrectly or that we're reading it incorrectly, but hopefully that's not the case. So again, this is the end of the presentation that I have for today. If anyone has questions, again, please let us know.
And Zainab, I liked your comment too. I think a lot of times too, that we had a similar thing happen in our first wave last cycle through. It just took a little while for the new procedures to start showing up.
Exactly. Mm-hmm.
It's almost like these first couple months are sometimes almost like baseline data.
Mm-hmm. Yeah. Well, we've talked about that actually as with the medical directors for the other projects too, that these first few months technically are like baseline data because you're implementing this new tool, and sometimes it can be difficult to capture everything that's going on. So again, please don't be discouraged if you're seeing lower numbers than you are in the real baseline in these first few months of QI.
Thank you.
Thank you so much, Zainab. So next we have, you may remember Dr. Lazaram from our kickoff presentation, who gave us a wealth of information about maternal mental health. And she's here back today to give even more great information and then also answer any questions, which I know if you have come in about maternal mental health. So if you have those questions, you can put them in the chat now, or feel free to unmute yourself and ask questions at the end as well. Let me make sure, there we go.
Okay, and Mark, and if you would be willing to monitor the chat box for me, since I'm unfortunately still on my phone and not on my laptop.
Yep.
That'll be great. This is just a little warm-up question. Everybody needs a little self-care, so The quiz question is, has the consistent consumption of chocolate been shown to decrease the likelihood of depression symptoms? Yes, no, or only dark chocolate is the question. And the answer to this, no surprise, is only dark chocolate really helps if you're depressed. So this is the season of too much busyness. Self-care may involve like some truffles or some other goodies, and I encourage you to do that for your mental health, or suggest this for those around you. So it's got to be at least 4 ounces a day, though. So just saying, there's a minimal amount that you at least have to achieve. So first slide, next slide. I want to say that I have CME disclosure. I have no relevant financial relationships, and I don't have any companies supporting this talk other than the Ohio AAP. And I do want to say that there's some little carrots that you'll see along some of the slides that give you some of the key information. So if you happen to see those little carrot marks, watch for those for answers to things that have come up before in discussions. Next slide. Going to go through like 4 little quiz questions of things you can expect to get answers to during this talk. Approximately what percentage of women experience postpartum depression? 1%, 2%, 10%, 50%? Make your guesses now. You'll hopefully know the answer by the end of this. Question 2. Maternal perinatal depression is associated with the following adverse outcomes in children: more missed appointments, early discontinuation of breastfeeding, poorer scores on cognition, language, and behavior that persist into childhood and adolescence, or all of the above. Next question. Which one of the following are associated with either screening or treatment of depression in women during the first 3 months following childbirth? This is a multiple choice, and there more than one is correct. So it has no impact on the incidence of major and minor depression. There's a significant decrease in both moderate, major, and minor depression at 9 months postpartum. And mothers who receive intervention had significantly better scores in functional outcomes of parenting, anxiety, and mental health at 1 year postpartum. Last question. When I use the CPT code 96161 to bill for caregiver screening for depression in Ohio, when can I use this? Only at the hospital newborn visit? All infant visits from birth to 2? Only the well child checks from birth to 6 months? Or every single infant visit from birth to 12 months of age? Okay, let's get into the presentation. We're going to be going through the whys of why it's important to screen. I'm going to talk through this fairly fast since I think I've all got those people who are doing the screening convinced of why this is important. We're going to talk about what clinical features would really set off your internal alarms that depression may be in play here, and what resources you can offer. And then we're going to talk about the hows. How do I get to implement this in the office effectively without using up too much of my time and get paid for this? Next slide. Okay, the whys of maternal depression screening. Let's start with kids. Kids who are exposed to maternal depression before the age of 1 are at risk for delays: social, emotional, cognitive, physical. They're less likely to get the benefits of ongoing breastfeeding. They have a lot more secondhand smoke exposure because the parent is much more likely, twice as likely, to go back to smoking after delivery. They don't come to your office as much. They don't follow up for preventative visits and get their immunizations on schedule. And when they are getting care, they're often using the emergency room. And there also seems to be a threefold increase in child abuse in children whose mothers have maternal depression. And this is common. 1 in 8 women report symptoms of postpartum depression. Next slide. And there's a downhill cascade of events that happen with this. Prenatally, yes, there's some adverse outcomes that happen with pregnancy, spotty prenatal care, low birth weight, preterm delivery. The infant has dysregulated behavior, more problems with arousal and inability to self-soothe. A toddler tends to be passive, has less autonomy, lower cognitive scores, interestingly. And by school age, these are the kids who may have more ADHD, a lower IQ, and more anxiety and conduct disorders. The adolescence, it plays out even more. ADHD and learning disabilities, lower IQ, and then segues into more alcohol and substance abuse, depression, panic, and conduct disorders. Next slide. And this trauma, childhood trauma, affects development of children. The depressed mom has a harder time responding to an infant's needs, and that affects the attachment style. So the depressed parent really reports much more negative interactions with the infant. This infant is fussy, this infant won't sleep. So the child becomes more depressed. Children have more behavioral problems, and they're at risk for very harsh parenting. And young children because of inattention, become much more vulnerable to events involving safety or even harm. And the ability to cope directly to caregiver's response, and this ability to cope is directly related to the caregiver's response to distress. Next slide. Young children often respond with sleep disturbance. They have increased arousal because they're waiting to see what's going to happen. Is the monster going to pop out from under my crib? They regress. They often revert back to a younger developmental stage. Behaviorally, they may be more passive and quiet because being quiet doesn't get them negative attention, and they're less secure about being provided with protection. So they become hypervigilant and sometimes have aggressive outbursts or exaggerated startle responses. And kids learn to do this because if you have an inattentive or low nurturing caregiver, they need to exaggerate the response to get the care they need. And we all know about adverse childhood experiences that this is a dose response to this. So this can carry on into adolescence and adulthood. Next slide. And it's just a negative feedback spiral that happens with this. The moms who have apathy and poor concentration have difficulty with poor limit setting, and so the child doesn't know how to regulate those emotions and behaviors. The mom who's irritable or anhedonia is unable to model appropriate behavior, and the child acts out then till they can get attention. The mother reacts and re-exposes the child to aggression, and the child expects hostility and aggression for many of these interactions. So now you've got an aggressive child, and they go back and trigger this mom who has minimal ability to respond. The mom becomes frightened and unable to soothe the child, and that results in anxiety and fear for both the mom and the child. Next slide. Okay, why am I doing this? The mom's not my patient. Why is this my problem? Because major depressive disorder peaks at 6 to 10 weeks postpartum, not at 2 weeks, not at the immediate postpartum period. A major depressive disorder, I just want to reiterate, is an Edinburgh that's 14 or greater, a PHQ-9 of greater than 10, and dysthymia, which is mild depression, also worth treating, peaks at 2 to 3 months, and then it tends to have peaks and troughs. There's another peak that happens at 6 months and again at 12 months. And these are the people who are the Edinburgh is in that in-between point, an Edinburgh of 7, PHQ-9 of 5. Most maternal deaths, we're very attentive to postpartum depression for 6 weeks, but most maternal deaths due to postpartum depression occur at 6 to 12 months, not 6 weeks. And the mom really doesn't get to see their doctor after that 6-week postpartum check, and often puts off going to their doctor for up to 18 to 24 months after a child is born. Next slide. And why do they, remember, there's 1 out of 8 women who have symptoms of postpartum depression. Sadly, women who have perinatal depression of any kind have a threefold higher risk of suicidal behavior. And that was highest for women who had postpartum depression in that first year. So, however, the risk will persist for up to 18 years. Next slide. And sadly, almost 2/3 of women with postpartum depression, it's never recognized. It's never screened for. They don't have a label for it. Of those women who do get their depression labeled, less than 10% of them who are diagnosed actually received evidence-based care. And why is this important? A single untreated case of postpartum depression can cost society almost $100,000 over the lifespan. And I want you to be kind of aware of some cultural concerns. There is a disparity between which women are willing to self-report without being asked. Hispanic and African American women with postpartum depression are more likely to bring this to your attention spontaneously, at least on one study done at 2 weeks, while white women are much longer to become recognized because they have some real self-reporting conflicts over privacy and disclosure. So if you don't screen, you're not going to know. If you don't ask, they won't tell you. Next slide. And about 1 out of 8 women report symptoms of depression after giving birth. But I don't want to forget that the dads here, because in families where there is maternal postpartum depression, up to 50% of the men also develop depression and anxiety. And there's a link to some studies that support that. So sad daddies are a real thing. Next slide. And why? Is there evidence for, should we be screening? Is there good evidence that this helps? Yes, they found that screening alone, just giving the woman a label, improves the rate of depression at 9 months. So if all you do is do the screen and you don't even hand out any resources, these women have improvement in their rate of depression at 9 months. And then we found that the Edinburgh tends to be the best postpartum, better, but PHQ-9 is still adequate. And there's really no negative consequences to screening. And treatment does improve health outcomes for moms, for the families. So there's good evidence that cognitive behavioral therapy and then meds will help, but any treatment improves depression and functional outcomes at 12 months. Is there any harms associated with treatment? None with cognitive behavioral therapy, but a very low incidence with meds postpartum. And some of that is just related to some differences with breastfeeding. Next slide. Why are we as the baby's doctor taking care of this? Why not? Because they're at the doctor's office for baby visits frequently. The standard screening intervals are newborn 1, 2, 4, 6, 9, 12, 15, 18, 24 months. And that's not even counting all those weight checks and acute visits. So you can make a difference here. A depression screening up through 12 months of age picks up 13% more mothers at high risk for depression. So don't just stop at 6 weeks. Take it out to 12 months. The AAP is recommending up through 6 months. The U.S. Preventative Services Task Force with good evidence now says take that screening right up to 12 months. And Ohio has responded by being willing to pay for that screening right up through 12 months. Next slide. Let's talk about the what's. Now that I've convinced you why we should be doing this, I want you to be able to recognize some of those red flags for depression. So maybe it's not a well child check and you're not doing routine screening, but you see that there's something going on with this family. Some of the risk factors are the unplanned C-section, the infant who has significant medical needs, an unexpected birth of a child with a genetic disorder, a mom who's had depression or postpartum or PMS before pregnancy has a higher risk of postpartum depression. People with lack of support, they may be single parents or they may be victims of domestic violence. have a higher risk of depression. And then just lack of sleep can trigger depression. Smoking, whether that's a sign that they're self-treating with their cigarettes or contributes to depression, I don't know. And clinical outcomes that you may be aware of that should also raise that concern. The kid who's often missing their appointments, but you're getting a lot of notes that they've been to the emergency room for a variety of things. The mom who stops breastfeeding early, or has very low confidence that they know what they're doing for parenting skills. And there's some resources that we'll talk about you can offer for that. Next slide. This slide, if you're going to copy one of all, I tried to summarize in one slide everything you can do about this. This is depression screening, and which scales you use, whether it's an Edinburgh or whether it's a PHQ-9. If their test shows no or minimal depression, you can still rescreen and offer peer or social supports as it may be needed. So if you see mild depression, that Edinburgh of 5, the Edinburgh of 7, and PHQ-9 of 5, definitely offer CBT or interpersonal therapy. And the second line may consider maybe an SSRI. If you have moderate depression, this is somebody who really needs it all. They need both. They need counseling and they need medication. And you might want to refer to peer or social support network as well, so that they've got more people to lean on. If it's severe depression, those moms that you're worrying have postpartum psychosis, may be at high risk for harm to themselves or others. Those are the ones you want to start the medication first. And then maybe doing the counseling, the CBT, after they start improving. SSRIs have the best evidence. There's SNRIs also have some good evidence for this. And there are some newer things that came out in the last year that are short-acting, rapid-acting therapies that are only used for treatment for a short period of time, but then have improvement in symptoms within 2 weeks. IV brexanolone is one of those, and Zurzuvae, I'm not sure I can say the other one, Zeranidone. The price on this is hideous. It's almost $20,000 for a treatment course that's only like a week's worth of medication. So you definitely want to have your mental health providers help you with this, because I don't even know how to begin to do the prior authorizations for those medications. Next slide. Okay. However, even if you're not the prescribing doctor, parents trust you. You are the child's doctor. And if they are breastfeeding, they're going to come to you with questions about, the doctor wants to put me on this medicine. I have a prescription, but I didn't fill it because I don't know how it's going to affect my breastfeeding. So you can be reassuring on a bunch of these things. The shorter acting SSRIs, the ones that have a shorter half-life, such as sertraline, otherwise known as Zoloft, paroxetine, known as Paxil, are preferred. You'd want the longer-acting ones like Prozac or fluoxetine, fluvoxamine. You just as soon not use during breastfeeding. But somebody who says SSRIs don't work for me, they want to use something else, SNRIs like venlafaxine has been worked well. And then tricyclic antidepressants have also been effective. Nortriptyline has good evidence and is safe with breastfeeding. Those of you who are as old as me and remember when nortriptyline was one of those first medicines you'd start for childhood ADHD, know that it has a good safety profile in children. I just would recommend avoiding doxepin because there's too much sedation with that. Next slide. There's also a lot of non-pharmacological treatment that can be useful for postpartum depression. Whether or not the mothers will have the energy to make that next step, to seek out that therapy or that support system, though, is always a problem. If you screen and you offer education and a resource, they've discovered, though, that women are 20% more likely to follow up with counseling or contacting an agency for help if you ask them if it's okay if you give them a phone call back to see how they're doing. So just tagging it so somebody in your office calls them in a week or two and say, hey, did you make a connection with therapy? Means that mother is 20% more likely to follow through. So, and there's a lot of community agencies you can engage with that can help with this. Head Start or Early Head Start, various infant and early childhood consultants. Help Me Grow is all of Ohio. We have Every Child Succeeds in the Cincinnati region. But in your location, find your local list of referral sources for moderate and major depression. And those people can also provide CBT, interpersonal therapy, or medication. Everybody needs to have their favorite psychiatrist. Next slide. There's also some national resources. I want to talk about. The 1-833-TLC-MAMA is a 24-hour hotline. It has just English and Spanish at this point in time, but it's available anytime. Next slide. And there's other resources that's also available through NAMI, which includes resources for postpartum depression support groups, as well as family support groups. Next slide. I want to go through just briefly some of the resources in one slide that has as many resources as I could find. Again, this is one of those other key slides. If you were only going to copy 2 of them, this would be slide number 2. The national resources are, as I mentioned, the 1-800 number and NAMI are 2 ones that are national resources, can use everywhere. It includes reference to that sad daddy, which not as many people are aware of. The Ohio resources that have been really useful for people before are for that parent who really has low confidence in their parenting style. The Triple P program through Ohio is a completely free parent education program that you can refer them to. There's also mom groups in Southwest Ohio. We have a breastfeeding coalition. There is Central Ohio has a group called POEM. And then Every Child Succeeds has a specific group called Moving Beyond Depression that's also in Southwest Ohio. There's also some video resources for families that want help with parenting. The Spark videos that you can use at the well child visit or caring for your newborn are 2 good resources that you can add in for any family. Next slide. There's also an additional Ohio resource that's specific for the breastfeeding woman, which is the breastfeeding hotline. This is new just in the last year. And so I really encourage people to consider using this resource, which seems to be abundantly well-staffed and has some really rich resources. Next slide. Okay, let's go to the house. How are we going to get this to work for you and your families? How am I doing on time, Mark?
We have about 15 minutes.
Okay. So how are we going to do the implementation to get this depression screening done? If the child is the patient at the well child visit, you can screen everyone. It's a vital sign. Just like you get a weight on a baby, do a PHQ-2 on any parent or honestly anybody who shows up as the caregiver for that child. So if grandma is now taking care of that infant because the parents are no longer in the picture, then you can certainly screen grandma with this too. Do a quick PHQ-2. If that's positive, you can go ahead and go on to do a PHQ-9 or an Edinburgh. Now, the Edinburgh is really specific for the birth mother at 0 to 12 months old because it's eliminated some of those questions we would expect to be positive in any woman postpartum, particularly regarding sleep and fatigue, which you do have in the PHQ-9 is not in Edinburgh because otherwise all Edinburghs would look positive. Next slide. But you can use a PHQ-9 on grandma or on dad. Next slide. Oh, go back. Did I miss one? Yeah, go back to the one before. Now, if the child is the patient, you can screen the parent for depression. Oh yeah, got that. Okay, next slide. Now, this doesn't have to be your work alone. Get the team to do the screening. When they're rooming the patient, they can do the PHQ too. And if there appears to be a problem, they can give them the PHQ-9 to fill out before you walk into the room. So, and remember, if that screen is positive, your MA should be able, MA or nurse, if you are so lucky to have a nurse rooming your patients, should be able to immediately say that PHQ-2 was concerning, and I'm going to do a better screen. So go ahead and give them the form. So PHQ-2 of 2 is normal. A PHQ-2 of 3, you should probably add a screen. Okay, next slide. And how do you want to make this standard work? If it's a standalone event, you're concerned, you're seeing a child back for their 3rd ER visit in the last few months, and they're behind on immunizations, and there's some red flags in your mind about what's going on. You can do the PHQ-9 not at a well child visit, but just add an illness visit as a standalone event. So build yourself a documentation smart phrase that incorporates the diagnosis and the billing codes into it. So it's easy just to pop that into your note, and empower the staff to administer the depression screening tools at the same time as any child development screening that may be happening. Now, as a standardized practice, something that you're doing all the time by every provider, is something that you might want to put into your well child visit. There's where you want to add the screening tool to your standard well child template. You can add the billing and the diagnosis codes to your preference list, your smart sets you may be using, and then make practice protocols so that your staff feels enabled to be able to really work at the top of their license, to start the screening process for you, to place charges for you to co-sign. So this doesn't all fall on you. Next slide. Okay, the screen's positive depression. What do I do now? Remember, even a brief interventions are effective. Let them know that you're here to help, that their health is also important as well as the baby's. Ask them if you can check in with them at the next visit. Ask if you can have someone make a call to make sure in a couple of weeks to make sure they followed through with resources, and offer those resources today so they've got something in their hand they can walk out of the office with. Some local parenting support groups have been very helpful for parent support. The baby cafes that have become increasingly popular, supported by many birth hospitals, have been a great resource for parents as a support group. The Leche, which is like Leche, a breastfeeding support that's specifically for Spanish women. Boobs, bless our beautiful sisters. Bless our beautiful, I don't know what the second O is, which is more common in our Southwest area, and Amen, which is also a group that supports breastfeeding. Centering Parenting is a good support for them. And the Triple P Positive Parenting Program is also a resource you can provide to any parent at any time. Next slide. Now, why are we doing this? Be prepared with those community resources. We do this screening because we have the resources that can help these families. They may not know where to start. We can at least get them started in the process. So just providing a community resources like a referral to Every Child Succeeds or Help Me Grow has shown to improve depression in moms at 9 months, even in mild depression. And if you screen, offer education, do permission for a phone call, 20% more patients contact the resources you gave them. So ask permission to share. And also you want to ask permission to maybe share a positive screen with the patient's preferred provider. So maybe they don't have one and you're giving them a list of primary care physicians they can see. If they say, oh no, I have somebody that I know, say, with your permission, can I share your screen that shows some depression, maybe they have some additional resources for you. If they say yes, then go ahead and send that on to their primary care provider so they can also be part of the team that looks out for this family. Next slide. Now, billing for this. Okay, you can bill for this. This is work you are doing and it should be compensated. If the child's the patient and it's a well child check or an infant visit, you can do the PHQ-9 or the Edinburgh to assess the parent for depression, or caregiver, I should say, because grandmas count too. So a CPT code 96161, which is Administration of the Caregiver Focused Health Risk Assessment Tool, which is the full PHQ-9, not the PHQ-2, or the Edinburgh. With scoring, will get paid. Ohio Department of Health pays for that screening at every well child visit from birth to age 1, as well as any illness visit from birth through age 1. Now, they only compensate $3.43, but commercial insurances like Anthem may compensate up to $30 for the screen. You want to tag it to the ICD-10 codes of screening, encounter for screening for depression or encounter for screening for maternal depression. Either one will get you paid. Next slide. And you want to document. So use your EHR tools for documentation. Considering for the follow-up, making it more apparent to you that you are taking care of this family, not just the child, but the environment that this child is in, adding one of these ICD-10 codes to the problem list for the child. So newborn affected by maternal depression, or adverse childhood experiences if it's caregiver depression, and you can route the notes to staff to do some of this follow-up for you. They can do that phone call back in a couple of weeks to see if they've or needing any help finding resources. And you can also use the reminder function in many EHRs to screen for depression at subsequent visits. So I am a big fan of my sticky notes to remember to ask just how are you doing at future visits? Have you made that connection? And for those of you who are not familiar, there is a new code that started just in 2024 called G2211. You can add this in addition to whatever E&M code that you're using, whether it's a well child visit check or it's an illness visit. And those office visits require more complexity of care or new referrals. So I encourage you to all start using this. If you've got a child, say you're seeing back for a follow-up from the ER for asthma, and you're coordinating care that they're now receiving for a pulmonologist, it's not just that follow-up visit about how their acute visit is going, but also you're following up on consultants' notes. G2211 is your friend. Next slide. Not as many people are as aware of this. And fee-for-service billing, you can also do things like risk-based assessments. So if you're doing a 99213, maybe it's a 99214 because of the amount of time you're spending on that visit, as long as you document your work. Now, the G2211 that I mentioned as an add-on code, I want you to start using it liberally. CMS, which is Medicare and Medicaid, pays about $16 for this code. Anthem, Humana, and Aetna are all paying for this as well in Ohio. Some of the other ones you have to kind of look up. That's hit or miss since this is such a new code. But as long as you're billing it with a code that includes something like child affected by maternal depression, then this is a legitimate thing to add into your well child visit. And remember, for those of you who do value-based contracting, documented consistent screening and referral for for any elements of social determinants of health is the basis for added payments within the medical home. So for those of you who are in those value-based contracts, this is also going to be a financial benefit to you as well. It doesn't give you, you're not going to be able to retire to the Bahamas on this, but it at least keeps the light bulbs on in your office. Next slide. Okay, let's go to the questions. I'm sure you all got this right because I only showed this about 1,000 times in the slide. What percentage of women experience postpartum depression? And the answer is 1 out of 8, or roughly 10 to 13%. Next slide. Question 2. Maternal depression is associated with the following adverse outcomes in children. All of the above. They have stopped breastfeeding early, they miss well-child appointments and immunizations, and they have poor scores on cognition, language, behavioral that persist all the way into childhood and adolescence. Question number 3. Which of the following was associated with screening or treatment of depression in women during the first 3 months following childbirth? There's a significant decrease in both major and moderate depression at 9 months just by the act of screening. And mothers who then receive intervention had significantly better scores in functional outcomes of parenting, anxiety, and mental health functioning at 1 year postpartum. So you can make a difference for this mom and a difference for this family by the screening that you're doing. Next slide. And when can I use that CPT code 16161 for caregiver screening for depression in Ohio at all infant visits from birth to 12 months of age, whether it's a well-child visit or an illness visit? So next slide. I have a list of references here. So those of you who say, I want to know the whys and the whats of this, these are the references that I found particularly helpful. And I put the U.S. Preventative Services Task Force one high up in this because it had so much good information that was fairly recent. But there's a bunch of other things, including that postpartum depression in dads information that was relatively new for me. Next slide. And also some references about implementation and billing that may be helpful for you as well. So if you're trying to optimize your workflow and set up a protocol that works well for your office, as well as finding some resources for this, this is a good place to go to. Next slide. Any questions? I did power talk through that fairly fast. So if you've got anything that wasn't clear, I said anything that wasn't clear, or anything I can answer more fully for you, feel free to let me know or shoot me an email in the future too. I do respond to emails.
Yeah, so I've got a couple minutes for questions if anybody has a question or two, maybe at the end here. But then also, I'm very thankful, I know, to Dr. Lazaran because she's answered a lot of questions that you all have sent to me. So that's a great resource.
So, and you'll be getting all these slides later. So if there was like too much information all at once, feel free to just piece out the parts of it that are useful. You can dig into these slides later to find some of these resources if you're building sort of a handout for your families to take home. So it's designed to be there as a resource you use.
And then just because we're short on time, I'll show this real quick and let everybody go after that. So November data entry I'll be asking for at the end of this month. We'll ask for that to be sent in by December 13th again so that we can have that for our action period call on December 18th. I pushed the meeting times back to 12:15 because I know some people had appointments that ended at noon, and so this gives us a little bit of time for a breather or maybe grab something to eat before logging into the meeting. So we'll plan to start at 12:15 for the next end of the program, the meetings each month.
And we still will get you out by 1 p.m.
Yes, that's the plan. Otherwise, I do want to thank Dr. Lazaran again for being a great resource for us and for today's presentation, and everybody for coming to the call today. I'll send out a recording of the call, the slides, and a reminder of our maternal depression resource that we have too that you can print as well. I have one quick question. Does anyone use Epic have a way of documenting screening in the EMR?
Our Epic has a field that allows us to do an Edinburgh in the well child visit. So as part of one of those many screens that you can do, there is a maternal Edinburgh. It was something that was imported at the request of our system. So while it's not a standard Epic build, it's fairly easy to move it from one screen where it's in the adult screen into the child. Ours unfortunately disappears at 12 months, but you can look back on it as a reference, but you can't actively put more data into it after 12 months.
Is that something that you can share, Betsy, if Emily needs to access that, or is it in the system?
It's in the system, so it's a active flow sheet that you can that's part of an Epic option. And so if you are using Epic already and they use other flow sheets like PHQ-9 or flow sheets like Vital Signs, then the Epic flow sheet is the Edinburgh flow sheet is by far the easiest way to do, because you can then do it at one point in time and look at it a month later and see if there's a change. So I can share just a quick smart phrase that includes the Edinburgh screening questions in it, but that's not nearly as useful as talking to your EHR, your IT people, and seeing if they can just build it as a flow sheet for you, because I guarantee they've already got it for the adult system.
Okay, thank you. I was told I couldn't put the Edinburgh results in the kids chart. It had to go in the parents chart, and then it had to be somehow linked. But sounds like that may not be true.
Yeah, you can link episodes. So often when they're in the hospital, you can link the baby's chart and the mom's chart are actively linked. And you can pull any data from the mom's chart and import it into the newborn visit, like what's the mom's blood type, what's the mom's Edinburgh, and that can be pulled right into the newborn visit note while they're still in the hospital together. Once you're outside the birth hospital, because hospital systems have that built already, they can certainly build it. It becomes in an active field after, or something that you can't add more data to after 12 months in our system. But Edinburgh is like a standard build in almost every hospital system. They just have to allow it in a different location, such as a child visit.
Okay, thank you. And
You're welcome.
thank you, Dr. Hudson, us too.
So send me an email if you want me to send you any smart phrases just for like your office visit.
All right. Well, thanks everybody for coming. I think most people have left at this point, but thank you all for attending today, and we'll see you next month.